Everybody can see the record sign. Is it recording or not recording? Hello?
Yes, sir.
Recording, sir.
Yes.
Good. Okay. So just one more minute and then we'll start. What is it, 5 o'clock? I don't know. What's the time? Okay, good evening, everybody. Welcome to a repeat session on pulmonary function test. We had a very, very fruitful session yesterday. We had a lot of question and answers, but unfortunately, a lot of people could not actually log in. Hence, I have agreed to do the talk again. It's a very long talk. It's almost 2.5 hours, but it's well worth doing it again for all the people who missed the talk and some people wanted to attend again. Okay. So first thing first, can you just give me a quick thumbs up that you can hear me and you can see my slide?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Good. That's fantastic. So that's a good start. The second thing is please check that it's recording. Can you see that it's recording?
Yes, recording.
Yes, sir.
having
It's
on.
Okay,
Yes,
fantastic.
sir.
And now everybody switch off your microphone, okay? So just switch off your microphone. Don't make me switch it off. You just switch it off, okay? Okay, all right. So today we're going to talk about ESTS guy. We're going to talk about pulmonary. Sorry. Okay, today we're going to talk about pulmonary function test. Mainly two perspectives. One is to understand what do you mean by pulmonary function test. Number two, how to actually do the test. Number three, what are the graphs that come out of the pulmonary function test. And number four, how to interpret the graph. So really how to understand what disease is being shown on the pulmonary function test. That's one part of the talk. The second part of the talk is what is the sequence of the test that you need to do when you're operating on a patient for lung cancer or when you're offering chemo or radiotherapy for lung cancer. So what is the guidelines which tells you which test to do first, which to do next, and things like that. And then the last and most important thing is what is the clinical application of this test. There's no point in knowing the test if you don't know how to apply the test clinically. So it's very important to understand that, and that is my aim. So at the end of the talk, once I finish the PFTs, I'm actually going to go through two important guidelines. One is the ESTS ERS guidelines for lung cancer therapy, and the other one is the ACCP. So today's talk eventually is going to end up with these two papers. The ESTS ERS guidelines, very, 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 very important. You can see the first author is Alex Brunelli. Alex Brunelli is president-elect of ESTS, and he's really a good guy and understands respiratory physiology in great detail, and probably has published the most in the world. So it's a very solid guideline. But the important thing to remember is 2009. So this was written in 2009. There have been a lot of updates since then, but nothing dramatically has changed to really bring out a new guideline. And the other guideline which I'm going to talk about today is going to be the one which got published, the ACCP guidelines, got published in CHEST 2013. So we are about 7 years down the line, but these are still very solid guidelines. And I will, again, you can see the lead author is Alex Brunelli. So, you know, it is, both papers are very important and you must get a copy of both the papers. Both are available freely online. The ESTS ERS guidelines is available on ests.org. And under that topic, if you go to guidelines, you will get the paper for free. So you can download the PDF edition. The thing is, it's a very comprehensive document. So it's a little bit of a pain to try and read through all of it. So that is why my talk becomes important, because I will actually give you the whole paper in a nutshell. And when I put points, there will be some bullet points in blue. Those are the ones that you need to follow. So my suggestion is when we come to that, please write them down and follow them in your clinical practice. The other thing before we start is I want to make sure everybody, please have a A4 size paper with you and a pen in your hand. And everything that we draw today, I want you to draw. Okay. So as I go through the whole, presentation, I will show you what to draw so that you should be able to draw every single graph of a pulmonary function test. Okay. So everybody, please have your own books and understanding. It's important. If you draw today with me, you will remember this for the rest of your life, and you will never forget PFTs, and more importantly, you'll never forget me. Okay? All right. So let's start off with what is high risk surgery. We are all doing high risk surgery. Okay, every day that we operate, it is high risk surgery. And the most important thing as surgeons, as thoracic surgeons, is to remember that the most important outcome of any surgery, no matter how good you are, no matter how bad you are, no matter how average you are, the most important outcome of any surgery is a live patient. Okay, a live patient goes into theater, a live patient has to come out, and the responsibility of making sure that your patient is alive is the surgeon's responsibility. And so it's not just about your operative skills. Okay, it's not what you do on table. What is really important is how do you choose your patient? How well do you choose your patient? And that is the difference between a good surgeon and a bad surgeon. It's not the operative skill. It is how well a good surgeon is selecting a patient who will actually get benefit from the surgery. So it is important to assess risk. It is very important to balance risk versus benefits. That is very, very, very important. And that is our job. Our job is not to operate. Our job is to balance the risk versus benefit. And we should offer surgery only and only if the benefit outweighs the risk. Never ever offer a surgery because somebody's paying you 10,000 pounds or 20,000 pounds or 100 million pounds. Never offer surgery. You offer surgery when you genuinely believe as a clinician and as a surgeon that your surgery will benefit the patient. The last thing you want is a patient who is dead on the table, who doesn't come off the anesthesia, or even worse is if the patient lands up in the ICU on a ventilator. That is very, very traumatic for the patient, for his family, and for you as well. To have a patient land up in the ICU is probably means that somewhere you have actually not balanced the risk benefit ratio properly, and somewhere you got it wrong, and that is why this patient did not come out of surgery. So as surgeons, we like to be brave. I know of a lot of surgeons who, think they have got big balls. They think they can really do anything and everything. And I've seen a lot of videos being flashed on our WhatsApp groups and YouTube groups. Look at me, how brave I am. I have taken out this big tumor, which is going into the pericardium, which is going into the left atrium, which is going into the right atrium, and I've done it minimally invasive, 3 ports, 2 ports, 1 ports. The reality is that the risk of the surgery is actually being taken by the patient and not by the surgeon. So anytime that people throw these videos on WhatsApp groups, my question is actually, did you explain to the patient what is the risk of mortality of this surgery that you're doing? And did you actually explain to the patient what is the risk of morbidity? Because at the end of the day, the person who's going to die is the patient, not you. So you can do any heroics that you like. It doesn't matter. But important thing is that the patient must understand the risk that is being undertaken. So don't really think that people are pleased by seeing these, very large tumors all over the place and you're going in and operating. That is not a brave surgeon. That is a foolish surgeon. So a good surgeon is one who understands the benefits, who understands the risk, and accurately balances the two and offers the patient the best treatment that is available for the patient. And very often the best treatment may be not to operate. You got chemotherapy, you got to respect all the specialties. In fact, sometimes it might be better not to offer any treatment, because the first rule of the game, the first rule of being a doctor is do no harm. And that is the most important thing to remember. So this whole talk is designed to make sure that you do no harm to the patient. Please select the patient carefully and well, and you will have good outcomes. And really, patients come to you when you have good outcomes. They don't come to you because you do one technique. They come to you because they see the data and they see that your patients go home safely. Nobody cares about access. What people care about is I should be alive at the end of the operation. So what is the assessment of respiratory function? How do we do the assessment? Why do we do the assessment? Well, important before you start the assessment is actually the history. So assessment of respiratory function starts with the history. It starts with looking at the symptoms of the patient. It starts with documenting what is the exercise tolerance for this patient. It starts with actually documenting the performance status of the patient, because this gives you the baseline physiological characteristic of a patient. Of course, you use investigations, things like chest X-ray, you use CT scans, you use ventilation scintigraphy, you use perfusion scintigraphy, or you can use VQ, which is a ventilation perfusion scintigraphy, a mix of the two, or you could use PET scan. All of this will give you information to decide whether this patient is fit for treatment or not. Most of us will use oxygen saturation as a basic measure using pulse oximetry. You can use ABGs, you can use formal spirometry, and you can use flow volume loop. Now, I don't know why these marks are coming. They are not my marks, but for some reason they are on the screen. But let's continue. When you assess respiratory function, some of the other factors are peak expiratory flow rate you'll measure static gas transfer, you'll measure gas transfer diffusion coefficient, shuttle test, 6-minute walk test, cardiopulmonary exercise test. So we're going to go through each of this in great detail. So today's talk may be a very basic talk, but you'll be surprised how many people do not actually know pulmonary function test. How many people think that they know? Even senior surgeons, a lot of people don't know the real nitty-gritty of a pulmonary function test. So the reason why we do PFTs is because we want to establish what is the baseline function. And it's not the anatomical function, it's actually the physiological function that we are trying to establish. We also do PFTs because we want to detect disease. We want to find out whether the guy has got obstructive disease, has he got restrictive disease, has he got intrathoracic outlet, intrathoracic obstruction, extrathoracic obstruction. All of these can be detected purely by understanding how to read a PFT. Once we have detected the disease, we give a certain treatment, like a bronchodilator. We need to know how well the patient is responding to the treatment. So we use PFTs to monitor progression. As surgeons, we should use PFT to know what is the post-operative outcomes for these patients. Did you actually benefit the patient? Did you really do the right thing for the patient? So also for your own audit, it's important to know not just the pre-op PFT, but it's important to know what was the follow-up PFT. I bet you 99 surgeons out of 100 will actually not do a follow-up PFT, 6 weeks or 3 months later. And that's not really good, because you need to know what are the outcomes of your surgery. It's not just about cancer, it's also about quality of life. So it is important to monitor the progression of the patient. And of course, as surgeons, we use PFTs for preoperative evaluation. One thing I forgot to say here is sometimes PFTs are used as a medico-legal tool. So you document the PFTs and then you use it, you help it in your medico-legal cases, or when people go for claiming for asbestos and things like that, asbestos exposure for occupational disease and all. A baseline PFT actually helps in those medico-legal cases. So it is one more reason why you would do a PFT. Now, before you do a PFT, it's important on the day of the PFT that the patient should not be smoking at least a few hours before this PFT, if not forever. So it is important to tell him to stop smoking. Don't just smoke and walk into the machine and try to blow. That will not give you good readings. It's recommended that you should have 4 hours fasting because these guys are blowing into the machine. You're asking them to do effort tolerance. You've got really asking them to sustain their accessory muscles of respiration, and you're asking them to push the abdominal muscles of respiration. And very often, if they've eaten a very heavy meal, there is a risk that they might actually end up vomiting. And the last thing you want is to vomit with a with a machine in your mouth. The chances are you will aspirate, and so you don't want any mishap. So preferably you should try and keep 4 hours fasting. Again, PFTs depend on not just the lung but the accessory muscles of respiration and the abdominal muscles. So it is important that the patient should be wearing loose fitting clothes, no tight fitting clothes, otherwise they will obstruct, they will actually give you erroneous readings on the PFT. Whenever we interpret PFTs, we have a standard predicted value. The predicted value comes out of the patient's age, height, weight, and body surface area. And the prediction is based on a population study. So they calculate like 100,000 people with the same age, same height, same weight. What will be their normal PFT? And then they give you a predicted value. And my personal suggestion to all of you is from today onwards, when you discuss any PFTs, do not mention absolute numbers. Absolute numbers have no meaning because an FEV1 of 1.5 in a 6 feet guy is different from an FEV1 of 1.5 in a 2 feet person. So it is not the absolute value that is important, particularly when we are talking about 0.8, 1 liter per minute. That is no good. What you really need to talk about is predicted values of normal population. So percent predicted is important. And you will find that all the guidelines actually are talking about percent predicted rather than the actual value. So when I go through the guidelines, you will see that it is all about percent predicted. Now the test should be done 3 times because it does take time for the patient to understand the technique of the test. Very often the test is not good because the patient didn't know how to blow. Particularly in the Indian scenarios, a lot of patients are illiterate or they are from the villages, and you try and explain to them, they're already worried about hospitals and machines and all that, and the technique is a problem. So it is very, very important to teach the patient the technique. Sometimes you do a couple of dummy runs and then you do 3 tests, and always, always, always the report is an average of the 3 tests, never a single reading. So it is very important to have a good patient technician who takes his time and supports the patient through the test. You can do dynamic studies, you can do spirometry, flow volume, PEFR, you can do static lung volume determination, and you can do gas transfer dilution techniques. And I'm going in fast over this slide because each one I'm going to go in great detail, okay? So let's start with spirometry. So this is a normal graph of spirometry. I want everybody to start drawing these, please. There is a y-axis which has got 0 to 5, its volume in liters, okay? Actually, it should be 0 to 6. So volume in liters is what you want. And then the x-axis is time in seconds. And then your spirometry is when a person blows into the machine, and this is a rapid rise of the curve, and then whatever stops at the first second, whatever corresponds with the 1 on the x-axis is your FEV1. As you follow the curve, the tip, the topmost part of the curve before it flattens is the first vital capacity. So this is FEV1 and FVC. Just draw this at the moment, and we'll go through each one of them, and I'll show you how it changes with different diseases. So please draw this. This is the most basic diagram. You should be able to draw this in an exam if I give you a piece of paper. So how do you do that? So spirometry is volume over flow rate of air entering and leaving the lung with the deepest breath in, and the patient blows into the machine and sustains the blow for more than 6 seconds. This is important. So you are doing maximum inspiration and then asking the patient to blow into the machine. So spirometry is really looking at expiration, not inspiration. It is looking at expiration. And it is important that the patient is compliant with the test. So the results of spirometry completely depends on how good the patient is and how well he has understood your instructions. So it is important that it is a test of expiration. And always there are 2 measures that you would get. The report is always given as liters per second. or percent predicted value. So you have to, the second value is better than using just liters per second. It's always better to give percent predicted value. The two numbers that you can really get with a simple spirometry is forced vital capacity, which is maximum peak that you can reach with an expiration, and the most amount of air that comes out in the first second. And really, once you have these two values, what you do is you calculate FEV1 over FVC. And this is a more sensitive ratio, gives you better answer of what is the pathology underlying the lung. Once you've done the first test, then what you do is give the patient bronchodilator, nebulization, wait for 10 minutes, and repeat the spirometry to see what is the reversibility with the bronchodilator therapy. And the reversibility, if it is more than 12% improvement or 0.2 liters per second, then it is considered a significant reversibility in the patient. Reversibility is a good sign because you do want to know whether the patient is responding to bronchodilator therapy or not. So reversibility is good. And that is why we do always a spirometry with normal and with reversibility. And the report will mention what is the response of the patient to reversibility. So what is forced vital capacity? I showed you that diagram. It's total air exhaled after deep inspiration and deep expiration. So it's really the peak of that graph that you're able to reach with a blowout into the machine. When we talk about capacities and volumes, you will realize that FVC is actually total lung capacity minus the residual volume, okay? And we'll talk about this in more detail, so don't worry about it now. The normal reading of an FVC is more than 80% expected, predicted. So always you will find that I will use percent predicted rather than volumes. Don't use numbers, use percent predicted. So if your report of FVC is more than 80% predicted, that is normal. If there is a reduction in the FVC number, it usually suggests a restrictive pulmonary defect. Okay, so a reduction in FVC is usually because of restriction. There are two types of pathologies in the lung. One is when there is an obstruction to the flow of air through the bronchi. That is called as obstructive pathology. Things like asthma, things like tumors in the trachea, these are all obstructive lung pathologies. They are causing obstruction to the flow of air. The other disease is where there is a problem in the parenchyma of the lung. So the parenchyma of the lung is not functioning well. There is fibrosis in the parenchyma of the lung, and that is restrictive lung disease. Okay, we'll talk about each in a bit more. So what is FEV1? FEV1 is the maximum volume of air that is exhaled in the first second after full inspiration. You'll be surprised how many times in the exam people are not able to explain what is FEV1. So many times I've asked this question to students, and really I'm surprised that people can't explain even FEV1. So it is important to understand it's the maximum volume of air exhaled in the first second after full inspiration, not normal inspiration, but full inspiration. Any value more than 80% predicted is normal. So anything more than 80% of FEV1 is normal. A decreased FEV1, but a normal FVC usually suggests an obstructive disease. So decreased FEV1, but normal FVC is obstructive disease. A decreased FEV1 with a decreased FVC is a restrictive disease. Okay, So FEV1 got usually gets decreased because you try to blow it out and something blocks it. But the rest of the lung is okay. So the problem is not in the parenchyma of the lung. The problem is in the outlet of the lung. So that is obstructive disease. So decreased FEV1, but normal FVC, obstructive disease. A decreased FEV1 and decreased FVC. This means that the parenchyma is affected. The lung is not able to expand. It cannot take in air. Hence, you cannot blow out air. Both the elastic recoil of the lung is lost. And when you lose elastic recoil, then both of them will go down, as a result of which you get what is called as a restrictive disease. Okay. But really, the number that has to be looked at is not the isolated number, but the ratio. The ratio is very, very important. So it is an FEV1 over FVC ratio. That is the one that you need to understand. So this is rate of flow out over total volume exhaled. That is the key thing. Okay. So how much can you blow out over how much have you taken into the lung? And normal is 75 to 80% predicted. So if an FEV1 FVC ratio is 75% or 80% or 90%, that is normal. I'm quite happy with that. When the FEV1 decreases, the numerator decreases and the denominator remains the same. So when numerator decreases and the denominator remains the same, the ratio goes down. And when the ratio goes down, that is suggestive of obstructive disease. Please shut off your microphone. Whoever is there, please shut off your microphone. It's ringing in my ears and really it's very disturbing. I can hear funny things in the background, please. Okay, so decreased FEV1 over normal FVC reduces the ratio, and that suggests this is an obstructive disease. And increased FEV1, a decreased FEV1 over decreased FVC, that means both the numerator and the denominator have both decreased. But the denominator has decreased more than the numerator, hence the ratio increases. An increased FEV1 over FVC ratio suggests that this is a restrictive disease. Did that make sense to you guys? Just give me a quick feedback.
Yes, sir. Yes, sir.
Okay, good. So
Yes,
it's
sir.
important to understand why the ratio has fallen down and why the ratio is increased. A lot of people do not understand why has this ratio increased. It should actually decrease because both the lung is gone and there's fibrosis. But the answer to this is that FEV1 decreases, but FVC decreases more. So when FVC decreases more and FEV1 decreases only a little bit, then the ratio will increase, not decrease. So this is the understanding of restrictive disease. Please, please, please switch off your microphone. Who is there? Please switch off. I can't do like this. Who's that? Atul Gupta? Dr. Gupta? Can't do like this here, please. I am again telling you again. I'll go back to doing it as a webinar otherwise because it's very distracting. Okay, this didn't make sense. Okay. So the next value which we sometimes use in our analysis is forced expiratory flow. Forced expiratory flow is an analysis in the middle of that curve, okay? So you want to know what happened at 25%, you want to know what happened at 50%, you want to know what happened at 75%. These are markers which will give you subtle changes. So your overall FPV1 and FVC may remain normal, but there will be subtle changes at 25%, 50%, 75%. And that actually sometimes helps the pulmonologist to identify subtle changes or early changes. And it is an additional graph that you can get out of the same spirometry graph, okay? So in an obstructive lung disease, your FEV1 is reduced. Please write this down. Your FEV1 is reduced. Your FVC remains stable. Hence, your FEV1 FVC ratio goes down. That is the understanding. This is the spirometry of a normal person. And here is your obstructive pathology. So your FEV1 has gone down. This was your FEV1. Here the FEV1 has gone down. Your FVC has has reduced, but to a lesser extent than normal. But your FEV1 FVC ratio is reduced, less than 0.7%. So this is a graph which is classical of obstructive pattern of lung disease. So what causes obstructive pattern? Well, bronchospasm, I said that. Anything in the airway will cause this. So bronchospasm, airway inflammation, increased secretions in the airway, loss of parenchymal support, loss of recoil of the airway, and things which cause all of this are asthma, COPD, emphysema, bronchiectasis, cystic fibrosis. So all of this will give you an obstructive lung disease pattern. Okay, so if it is less than or equal to 80% predicted, the disease is mild. It's less than, not more than. It's less than or equal to 80%, it's mild. If it is less than or equal to 50 to 75%, it is moderate. If it is 30 to 49%, it is severe. And if it is less than 30%, it is very severe. So those are the figures that you follow for mild, moderate, severe, or very severe obstructive lung disease. Very often you see the report and it says mild obstructive lung disease. So this guy is around 80%, okay? If it says moderate, then that's 50 to 79%. So this way you categorize what is the disease pattern that you have. What about restrictive lung disease? In restrictive lung disease, you have a reduced FEV1, we said that, but you also have a reduced FVC. So your ratio may be normal if both the reductions are the same, the numerator and the denominator reduce to the same extent, your ratio will be normal. But if the numerator reduces to a lesser extent and if the denominator goes less than the numerator, then your ratio will be increased. There is more decline in FVC than FEV1, as I said earlier. And in this, in addition to the FEV1 FVC ratio, if you've also got TLC and RV, it will give you a better understanding of restrictive lung disease. But stay with this last statement because we are going to talk about TLC and RV at the moment, later on. So this is your restrictive lung disease. Your obstructive lung disease was like this. The restrictive lung disease is completely flat. Reduced FEV1, reduced FVC, but the ratio remains normal. Okay, so both have gone down, but the ratio has remained normal. So it's quite important to understand this. Okay. I don't know why I've got these blue marks on the screen. 1 second, I'll just try and go back. I'll stop the share and come back again. Just 1 minute. So that has gone, because sometimes when I move the cursor, it gets recognized as a movement. So what are the lung pathologies that cause restrictive lung disease? Idiopathic pulmonary fibrosis and sarcoidosis. These are the important lung disease which cause problems with the parenchyma of the cell, okay? With the parenchyma of the lung rather than the airway obstruction. You can also have restrictive lung disease because the outside is compressing the lung. The lung is not able to fully expand. So things like obesity, things like asbestosis, because your pleura is now contracted and the lung gets trapped in the pleura. Pectus excavatum is a classical example. Severe pectus excavatum can cause compression on the lungs and cause this problem. Severe kyphoscoliosis can also cause this problem. And neuromuscular disorders which affect the movement of the diaphragm, movement of the chest wall can all compress the lung and cause what is called as restrictive lung disease. Mild is 70 to 79% predicted, moderate is 60 to 69, severe is 50 to 59, and very severe is less than 35. So this is a classification of restrictive lung disease on the basis of spirometry. Okay, is everybody clear about spirometry? This was the first test that we do. Did you understand that? Okay,
Yes,
now
sir. Yes, sir.
get your pen and paper out, because this is the most important one. That is flow volume loop. How do you draw a flow volume loop? I was personally asked to draw a flow volume loop in my FRCS exam. On the Viva table, the examiner gave me a paper and said, draw me a flow volume loop of XYZ. He asked me 3 or 4 and I could draw them. So it's important to learn how to draw this. But most important is to know what is normal. Very often people know the abnormal, but they don't know what is normal. How do you interpret a normal flow volume loop? So draw a y-axis, a long y-axis, vertical y-axis. Halfway point of the y-axis, draw an x-axis. The y-axis is rate of airflow. The x-axis is the total volume of air that is inspired or expired. But this is not, that's why I told you to draw halfway through, because the area above is expiration and the area below the x-axis is inspiration. So the negative limb that you get is an inspiratory limb, and the positive limb above the x-axis is an expiratory limb. And peak expiratory flow can also be measured from the flow volume loop. Now you've got this blank diagram with an x-axis and y-axis. I have seen many times I've asked people to draw and they start drawing from here, as we naturally do. And they draw this and come out here. That is not how you're supposed to draw a flow volume loop. Very, very clear. A flow volume loop, you draw the y-axis, you draw the x-axis, and you start here, because inspiration starts here. So you always draw the flow volume loop reverse, not forwards. You go against the thing. So you come from right to left, not left to right. Okay. So this is the flow volume loop. You start at the peak number there and you come down, because inhalation comes down. This is air going into the chest. And you never touch this junction of x-axis and y-axis. You always stay short of the junction, and then you blow out. You've just done a peak flow, and then you gradually maintain it, and then it comes out. This is normal flow volume. A breath in and a breath out. Breath out always starts with a gush of air and then flows down. And this peak is called as the peak flow in a normal breathing. Okay, so this is how you do it: inhalation, exhalation. Okay, always this slant is also quite important. All right, now I'm not going to talk about these volumes and capacities at the moment. Just stay with this. This is inhalation, this is exhalation. Okay, so what is a normal flow volume? There's a rapid rise of expiratory peak, there is a linear fall, and there is a saddle shaped inspiration. Jigger, shut off your microphone. Jigger, please switch off your microphone. Thank you. So there is a saddle shaped inspiration, there is a rapid rise of expiration, and a linear fall of the expiration. Okay, that's important to understand. So these are all the volumes that you'll get. Don't catch on to this at the moment. We'll go through each one of them in a minute. So what do you get in an emphysema, in an obstructive disease? So in an emphysema, the key thing is that the descending portion of the expiration, the slant of the expiration actually becomes concave, because there is obstruction to the outflow. Okay, so there is collapse of distal airway in an emphysema, there is loss of elastic recoil, and there is reduced expiratory flow. It's always an outlet problem, not a inlet problem. So inspiration remains normal, but expiration gets affected, and usually the first flow comes okay, but then the airway collapses because of the loss of elastic recoil, as a result of which the curve, instead of sloping straight, actually becomes a concave. So this is what you have to draw. Now, if you ever draw any of these curves in the exam, for God's sake, please draw the normal curve first, always. In an exam, draw the normal curve first. And once you draw the normal curve, then on the normal curve, you show us what is happening in a emphysema. So in an emphysema, the inspiration remains normal, follows the normal curve. The expiration, the peak flow is reduced, and the slant or the inclination of the flow is decreased because there is obstruction to the outflow, or there is obstruction to expiration. So this is what is an understanding of an emphysema patient. Okay, everybody clear about this? Is this very clear?
Yes, sir.
Yes, sir.
So the next one is intrathoracic upper airway obstruction. What is a variable intrathoracic upper airway obstruction? What do you mean by that? So these are the things. If you've got tracheomalacia, or you got polychondritis, or you got tumors in the distal trachea, or you got tumors in the main bronchus, then there is an obstruction to the flow of the air, but it is within the chest. This is not outside the chest. The obstruction is within the chest. So what happens in that is, because there is obstruction within the chest, you're able to take in the breath. Taking in breath is not a problem, but obviously taking in breath is less than normal. You can never do the same peak. So breathing in is not a problem, but it's still a shallow breathing. So it's a shallow inspiration, but when you try to expire, the first half is okay, but you cannot reach the peak of normal, but the rest behaves exactly as we saw in emphysema. That means there is a concave pattern to the slope of the expiration. So there is an obstruction to outflow of the air. Inflow is also affected. The peak is less, but still the curve is maintained. So that's not a problem, but it is the outflow that is really a problem. And that is classical of an variable intrathoracic upper airway obstruction. Okay. So what happens is there's narrowing and collapse of the airway. So the extraluminal pressure is more than the intraluminal pressure during expiration. So inspiration peak goes down, but it is really the expiration that gets affected, because the negative pressure in the chest pushes against the airway. And so the extraluminal pressure becomes more than the interluminal pressure. Hence you get this concave appearance on the slope of the curve. So there is plateau across the expiratory flow. There is decreased airflow during forced expiration. However, inspiration remains normal, but the peak is less. Okay. Again, this is exactly what I said. So go through this again and understand that. Okay. This is a intrathoracic upper airway obstruction. So something like this, intrathoracic upper airway obstruction. The pressure here is more than the pressure here. Okay. Never mind the graph. Just stick with this. Okay. Extrathoracic upper airway obstruction. Variable extrathoracic means outside the chest. I always had problems understanding this. What is the meaning of extrathoracic upper airway? It's very simple. Extrathoracic means the block or the obstruction is outside the chest. So what are the clinical conditions which will cause a block outside the chest? So you can have vocal cord problems, you can have unilateral palsy, or you can have bilateral palsy, okay, a adduction of the vocal cord, both of which will cause a extrathoracic upper airway obstruction. You can have laryngeal edema, so there will be outflow obstruction to these patients, or you can have obstructive sleep apnea, where the tongue is falling back, the soft palate is touching the tongue, and there is a outflow obstruction to these patients. So it's an obstructive sleep apnea. What happens in an extrathoracic upper airway obstruction? The physiology is that airway is narrowing. We've understood that. The extraluminal pressure is more than the intraluminal pressure. We've understood that from the previous experience. And inspiration is also affected. So there is reduced inspiratory flow during forced inspiration. However, expiration remains normal. So it's not a problem of expiration. Extrathoracic outlet is a problem of inspiration. So inspiration gets severely affected. Expiration is okay. You're able to blow out, but you're not able to blow in. And so your expiratory curve remains normal, but the inspiratory curve starts off okay, and then a sudden cutoff. So suddenly there is a plateauing of the inspiratory phase, and then you go back and you try to blow out, and the blowing out is okay. It's the inspiration which causes collapse, not the expiration. So this is the classical thing of extrathoracic upper airway obstruction. Okay. Now, if you look in this corner, all of them have been put in one, and I'll show you that at the end when we have finished with this. So we've looked at intrathoracic upper airway obstruction. We've looked at extrathoracic upper airway obstruction. What happens in a fixed airway obstruction? What do you mean by a fixed airway obstruction? Well, fixed airway obstruction can be endobronchial tumors, can be goiters. That means they are just there. You cannot push against them and open up the airway. Tracheal stenosis, again, contracted. There is no way you can push it open or push it closed. It stays in one place. Or main bronchostenosis. These are all clinical conditions which will cause what is called as a fixed airway obstruction. So what happens in a fixed airway obstruction? There is a fixed obstruction to flow of air. So it is both inspiration and expiration. So you cannot blow against, you cannot blow it open during inspiration or blow it open during expiration. Both are actually cut off. So what you get is a plateau of flow both in inspiration and in expiration. So you get this diagram. This is normal, but you get a complete plateau of the tip and then complete plateau of the tip in inspiration and expiration. And this is classic of fixed upper airway obstruction. Okay. So draw this diagram, everybody. So this is a fixed upper airway obstruction. What do you get in a restrictive disease? What do you mean by, we spoke about it, interstitial lung disease, idiopathic pulmonary fibrosis, sarcoidosis. So here the parenchyma of the lung is affected. So there is a problem with the parenchyma of the lung. So the flow volume loop shapes are normal. The shape is normal due to absence of airway obstruction. So there is no airway obstruction, but the flow volume loop is reduced in size because the lung is not doing exactly what it's supposed to do. So the peak of expiration and the peak of inspiration is reduced. That is what you have to understand. So this is not about like the fixed where there is a cutoff. Here, there is a peak is reduced and the volume overall is smaller because the lung is restricted. You cannot take in that much breath. Your FVC has gone down. So you cannot take in as much breath. And so your whole volume will look smaller. So it is a similar volume shape to normal flow, but smaller in size. So it is the size that is smaller. So here you can see that this is your normal thing, but because there is restriction, you can only start with half. So your residual volume is very high, and you're just starting much beyond the residual volume, and you are hardly able to come to the peak. Your peak is reduced, and here again your peak is reduced. So slope is normal. The slope is not a problem. It is the peak that is a problem on both of these. So it is a reduced peak on the inspiration, a reduced peak on the expiration, and increased volume, residual volume. So you start more laterally towards the midline, more laterally towards the x-axis. So you cannot start from here. This diagram, you have to start from here. And you go like this and just do a half the diagram that you do normal. So important thing to understand is whenever you draw this volume loop, you must draw normal. The most important thing is you have to draw normal. When you draw a normal volume loop, only then will you be able to represent an abnormal. Okay, so it's quite important to understand that. So this is the pattern of all of them over a single graph. There are lots of photos on the internet. Please download them and take them and try to draw your own thing. The only way you will be able to draw is when you understand the philosophy behind what is happening. That is why I take the trouble to explain to you what exactly is happening, physiologically what is changing. And once you have in your mind what is the clinical condition, then you are able to give me an answer. And this is one of the best loops. This is the way I studied it, that I drew the normal and every single thing I would draw within the loop. And when I draw everything one superimposed on top of the other, it clearly differentiates the differences between the various loops. What is the exact change that is happening between the 5 conditions? Okay, so this is a real cracking question in the exam. I love it when this comes, because this is something where you can do things and show to the examiner that you genuinely understand respiratory physiology. That's what you're trying to show when you draw this exam. So this is the one that you must practice again and again. Because when you do it on the same one, you actually are able to demonstrate what is the difference between the various things and why the peak is low, why the inspiration is cut off, why the expiration is cut off. So it's very important to understand that. Okay, is it clear, flow volume loops?
Yes, sir.
Yes, sir.
Okay, good. So we'll stay there. We'll take all the questions at the end, if that's okay. I don't want to stop the flow of the things. So next one we come to is volumes and capacities. Now, the key thing is 4 volumes and 4 capacities, okay? So write down this: tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Okay? Tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Now, very often on the table we say, reduce the tidal volume of the lung to the anesthetist when we are operating, when the lung is coming in your way. But do you really understand what is tidal volume? So that is why this graph is very important, because it makes you understand what exactly is the change that you're seeking in the lung. The 4 capacities are vital capacity, total lung capacity, inspiratory capacity, and functional residual capacity. Okay, so vital capacity, total lung capacity, inspiratory capacity, and functional residual capacity. So I want you to start with one x-axis, with one y-axis, and draw 0 to 6, because that is the total lung capacity. So 0 to 6, that's volumes in liters. Then draw your horizontal line, which is the x-axis, which is time in seconds. You don't need to mark the time in seconds. At around 1.5, draw a line, because 1.5 liters is the residual volume. At around 2.5, draw another line. At around 3, draw another line. So 2.5 to 3 is only 500 ml difference. So that's the line you draw. And then you start tracing your breath as you go along. So when you take a normal inspiration and normal expiration, draw these. Draw a couple of loops of normal inspiration, normal expiration. The volume that you take in a normal inspiration and a normal expiration is 500 ml, is called as tidal volume. Okay? The volume that you take in, 500 ml, inspiration and expiration is tidal volume. Once you finish expiration, you take in a deep inspiration. The deep inspiration is inspiratory reserve volume. The volume of tidal volume over plus the maximum inspiration is inspiratory reserve volume. Once you've taken a deep inspiration, you then blow out to normal and go beyond to maximum expiration. Blow, 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 blow. So you blow out to beyond maximum expiration. Okay? And then you come back to normal. All right? So just stay with me now. I will not talk about the capacity. I'll go into each one of this and I'll show you the diagrams as I go on. So what is tidal volume? It is the volume of air at normal inspiration at rest and normal expiration at rest. And we said that that's 500 ml. Is that clear? And if you want to put it in ml per kg, it's 6 to 7 ml per kg. So you can, you can show changes for height of the patient. So this is tidal volume. Okay, dub, 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 dub. Okay. Now, what is inspiratory reserve volume? Inspiratory reserve volume is the additional volume of air over and above the tidal volume when you take a deep breath in. So inspiratory reserve volume is tidal volume plus the additional volume of air. So see this? This is your, where is your IRV? This is IRV from year to year. So here is your tidal volume, and inspiratory reserve volume is above this. This is IRV, above it, inspiratory reserve volume above the tidal volume. Expiratory reserve volume is additional volume of air over and above the tidal volume. So it is below, that's negative, okay, when you forcefully breathe out. So this is expiratory. The blue, everything that's blue here is expiratory reserve. This is normal expiration. Over and above normal expiration, what you're doing is expiratory reserve volume. So ERV, IRV. IRV is all of this beige color pattern is IRV. All of this blue color pattern is ERV. The purple is tidal volume. And after maximal expiration, what is left behind in the lung, which is to the tune of 1.5 liters, is residual volume. Is this clear? Everybody understood this, or you got confused?
Clear, sir.
So tidal volume is 500 ml. Inspiratory reserve volume is over and above tidal volume, about 3 liters. Expiratory volume is over and below tidal volume, which is about a liter, 1.5 to 2.5 liters. So that's about a liter. And residual volume is what is left behind in the lung because of the elastic recoil of the lung and because of the interpleural pressure. There is something left behind in the lung so that the lung does not completely collapse, so that there is a little bit of rigidity still maintained. That is why you have what is called as a residual volume. So residual volume is the volume of air left behind in the lung following maximal expiration. This prevents the lung from collapsing. So this is residual volume. Everything that is green is residual volume. Blue is expiratory reserve. Purple tidal volume, and cream is beige is inspiratory reserve volume. So now you combine these volumes to understand what is capacity. Okay, so capacity is a combination of these 4 volumes, and that gives you capacity. So vital capacity is volume of air on deep inspiration and deep expiration. Okay, so volume of air on deep inspiration and deep expiration. So it is tidal volume plus inspiratory reserve volume plus expiratory reserve volume. The one that you don't include in vital capacity is the residual volume. Is that clear? So RV does not get included in vital capacity. So 1, 2, and 3. So vital capacity is inspiratory reserve volume, vital capacity, tidal volume, and expiratory reserve capacity. Okay, so 1, 2, and 3. Beige plus blue plus purple is vital capacity. Total lung capacity is amount of air, total volume of air in the lung on after maximal expiration. So it is vital capacity plus the RV. This is TLC, okay, it's not VC, it's TLC. So TLC is vital capacity plus RV, which is 4 to 6 liters. Is that clear? So beige plus purple plus blue plus green is white, is total lung capacity. Yeah, from the top to the bottom. Look at this one here. Is this clear? Okay. The next one is inspiratory lung capacity. So if you are already thinking and you've understood what the game is, then you will know that inspiratory lung capacity is maximum volume of air that is inspired after normal expiration. So tidal volume plus IRV. So inspiratory capacity is purple plus beige is inspiratory capacity. Functional residual capacity is the volume of air after normal expiration. So it is expiratory reserve volume plus residual volume. So FRC is blue plus green. Blue plus green, that is expiratory reserve volume, functional residual capacity. So four capacity, this is expiratory capacity, this is inspiratory capacity, this is vital capacity, and this is total lung capacity. So four capacities and four volumes. It's very, very, very important to understand this. This really matters when you are trying to differentiate between the various diseases. So now the question is, we have understood the graph, but how the hell do you measure it? So spirometry measures vital capacity because you do deep inspiration, deep expiration, but it cannot measure residual volume. Because spirometry does not measure residual volume, it cannot measure FRC, and because it cannot measure residual volume, it cannot measure TLC, because residual volume is part of TLC. So you need various techniques for doing it. So the various techniques for doing a lung volume or a lung capacity is as follows. The first technique is called as closed circuit helium gas dilution. So you inhale a known concentration and a known volume of inert gas. Okay, so now you know exactly what has gone in. You wait for 7 to 10 minutes so that the gas has caused equilibrium in the alveoli, and then you measure the exhaled helium concentration. So what is coming out? And using that, you calculate what is left behind, because what is left behind will give you the functional residual capacity. So this is how you do it. You sit here, a known quantity of gas goes in, a known quantity of gas comes out, you do the readings, and once you see, this is the gas going in, this is the gas coming out. So you're doing readings at inspiration and you're doing readings at expiration, and then you use a formula, the computer does it for you. But the important thing is to take away the dead space. So this is the dead space from year to year, okay? So the computer actually calculates the dead space according to the height and weight of the patient, and it takes it away from that reading and gives you actually a reading of what is FRC. And that gives you value when you are trying to do. And so the test comes out like this, and what you really are looking at percentage predicted, okay? So you can find out TLC, you can see FRC, you can find out RV. So all of this actually gives you a percentage predicted, and you use the analysis. The other technique for doing this is what is called as an open circuit nitrogen washout, okay? In an open circuit nitrogen washout, you actually breathe in 100% oxygen. That's what you give. The oxygen displaces the nitrogen in the respiratory epithelium, and you exhale that nitrogen out, and you measure how much was inhaled, how much was exhaled, and the difference between the two gives you the amount of intrathoracic volume. And indirectly, once you know the intrathoracic volume, which means once you know what is the residual volume, you can actually calculate the functional residual capacity. So it's really, the whole game is about calculating what is left behind in the lung, what is the residual volume. So this is how you do it. This is the thing you're going in, but the sensor is here, right here, and it is analyzing how much nitrogen is going in, how much nitrogen is coming out, and it does a calculation for the dead space. And then so A minus B divided by whatever is the dead space gives you the calculation of how much nitrogen, and indirectly, it's an indirect measure. So indirectly, it tells you what was left behind in the lung. The real one that you use in clinical practice, which most of us use, is called as whole body plethysmography. In a whole body plethysmography, the patient is actually sitting in a chamber. This is a pressurized chamber. You can actually close it, and you can increase the pressure or decrease the pressure, and you can read the measure of the pressure in the chamber. Okay, The patient is asked to breathe in here, and really what is applied is Boyle's law. Now, Boyle's law says that the volume of gas is inversely proportional to change in pressure. So whatever pressure change that is being measured in this chamber can be used as a calculation to actually identify what is the change in volume of the gas that's going in and coming out. Did you understand that? So it is an indirect application of Boyle's law. So what you do is you sit in a closed box, the pressure is applied to the body, a known pressure is applied, a known amount of volume goes in with the voluntary respiratory efforts by the patient, and the change in the pressure to the volume is recorded by the machine. And the change in the pressure using the Boyle's law is then translated back into volume. So you don't actually measure the volume, you actually measure the change in the pressure of that chamber. And that is what gives you the idea. So you measure total air that's going in. The good thing about this is because you are not just, it gives you a representation of the whole lung, the whole chest. So this is the only mechanism where you can actually measure how much is the gas trapped in bullae, particularly in large bullae, in emphysematous diseases. It's very, very good to actually use this technique because it measures the gas that is trapped in the bullae as well. So many different volumes can be calculated instantaneously by just measuring the change in the pressure. So FRC is calculated, and then once you know the FRC, then TLC can be calculated. So really, the residual volume is beautifully captured by whole body plethysmography. So we have done all of this, but what is the clinical significance of this? How do you do that? So the clinical significance of this is that you use lung volumes and capacities in obstructive and restrictive disease. In an obstructive lung disease, the RV is increased, the TLC is increased, and the RV-TLC ratio is increased. So all three of them are increased. So there is a lot of air that is left behind because you cannot blow it out. Hence, the RV is increased. The TLC, which is a direct correlation with the RVC, is increased. And because both are increased, the ratio is increased. It suggests hyperinflation of the lung. It suggests, Bullous disease, emphysematous disease. So there's lung being trapped behind there. RV may even approach the level of FRC, which means that a huge amount of volume can be left behind in the lung. You're not even able to blow out the air accurately. And the VC is relatively normal. So the inspiratory and expiratory things are okay, but the residual volume is very, very high. And that is how you diagnose obstructive lung disease in whole body plethysmography. In restrictive lung disease, what is happening is there is a restriction to the movement of the lung. So there's a compression of the lung. And because there is a compression of the lung, the residual volume decreases. As a result of which the total lung capacity also decreases. Inspiratory, expiratory effort is not great. So RV is reduced and TLC is reduced. And the ratio is reduced. And as a result of that, the inspiratory capacity is also reduced. So it's important to, these are calculated numbers. The second and the third and the fourth are calculated numbers. But the volumes are exact volumes that are got from the reading. So the computer actually calculates the other numbers for you and tells you. And once you get this sort of a pattern on your report, then you know that you're dealing with a restrictive lung disease and not an obstructive lung disease. Okay? Is it clear so far? Volumes and capacities, have you understood?
Yes, sir.
Okay, good. I'm happy.
Yeah, one question.
Mr. Su, take all questions at the end. Don't take it now because it will stop my flow of thought. Okay, so gas transfer. Let's go to the next test, which is gas, because this is a very long topic, this one, and I don't want to stop. But come up with the questions at the end. So gas transfer is looking at diffusion of gas between alveoli and blood. The gas transfer is directly dependent on the alveolar surface. It is dependent on the alveolar capillary perfusion. It is dependent on the alveolar capillary interface. It is dependent on the volume of the capillaries that are present in the lung. It is dependent on the hemoglobin concentration, because higher hemoglobin, higher oxygen can go across. And it is calculated using the phenomenon of affinity of carbon monoxide to hemoglobin. Okay, because carbon monoxide readily attaches itself to hemoglobin as a preference over oxygen. So if you've got oxygen and carbon monoxide and you put in hemoglobin, carbon monoxide will occupy all the receptors for the oxygen, and oxygen cannot be absorbed. So we use that affinity to identify all of this, and that's how we do gas transfer. How do you measure gas transfer? So you measure it using a unit called as DLCO, which is diffusing capacity of the lung for carbon monoxide. Okay, so a lot of people don't know the full form of DLCO. I found this in the exam that when we ask you what is DLCO, they don't know the full form of DLCO. They just know it's DLCO. They use it every day in their practice, but they don't know what is the full form of DLCO. And the unit for measurement of DLCO is ml per minute per millimeter of mercury. The same thing is represented in a different way with a different unit. If you use millimoles per minute per kPa of pressure, then it is called as a transfer factor of the lungs for carbon monoxide, TLCO. It's more or less the same. DLCO and TLCO are similar representation, except that the units of measurements are changing in DLCO and TLCO. And then what we look at is the volume of carbon monoxide that is transferred into the blood. And we also want to measure the alveolar partial pressure of carbon monoxide. Okay, so it's not just the volume, we are also trying to measure what is the partial pressure of carbon monoxide in the alveoli. And so it is a product. If you do a product of alveolar volume and transfer coefficient, then you get what is called as a KCO. A lot of people don't know what is a KCO. KCO is a product of alveolar volume into the transfer coefficient, and that gives you KCO. Okay, so stay with me with these words because we'll understand more in a minute. So why are we using carbon monoxide? We are using carbon monoxide because it has a high affinity for hemoglobin, so easier to measure. The most important thing about carbon monoxide is it is not present in the alveoli. So anything that you measure which gives you carbon monoxide is from the outside. It was never present there, you gave it in. So the whole volume that you get is represented to the exact amount that you put in. Okay, so it is not normally present. Very often other gases are present, and so you might get a mixture of results. You might not know how to interpret that. But carbon monoxide, very specific, everything that goes in gets measured. And so it's a more accurate answer. It is only goes across by diffusion. It is not affected by perfusion. Carbon monoxide very readily just sweeps up across the membrane, and how much amount of blood comes in through the perfusion does not affect the amount of carbon monoxide that is taken up, because it is readily diffusible. Okay, so that's why carbon monoxide is used to understand this test. So how do you do this test? You do what is called as a single breath holding test. You inhale a known volume of a test gas. What does the test gas contain? It contains 10% helium. You cannot give 100% carbon monoxide. Patient will die. Okay, the moment you give 100% carbon monoxide, he will die with carbon monoxide poisoning. So you give a very low dose of carbon monoxide, not 0.3%. So you add helium, which is an inert gas. You give a little bit of carbon monoxide with it, but then you give the mixture of air. So 21% oxygen and 68.7% of nitrogen, that's the mixture of air. Plus this, you ask the patient to inhale and hold the breath for 10 seconds. When the patient holds the breath for 10 seconds, you reach equilibrium, and then you ask the patient to exhale. You do not measure the first volume of gas that is exhaled, because that volume is representative of the anatomical dead space and the mechanical. Mechanical means what is there in the tubes. So that you let it wash out. The first amount of gas that you measure, you don't use it in your calculation, but it is the second amount of gas that comes out. You use that for your calculation, and that gives you exact representation of the alveolar sample. So the air that is present in the alveoli then is tested, and that is analyzed for the amount of helium and carbon monoxide coming out. And that gives you an exact reading of how much has come in, how much has gone in, and how much has gone out. So here you are. Here is the carbon monoxide with the molecule. It's going very easily across. It is latching onto the RBCs. And what you're trying to measure is the alveolar concentration of carbon monoxide, and you're trying to measure the diffusion of the carbon monoxide across the alveolar membrane. Okay, these are the 2 points that you want to measure. So you're really looking at DLCO. So here is the patient sitting in the machine. He's got a mouthpiece here. Here is the recording device, which is recording what is happening. You take a fast and deep breath in of a known quantity of the gas, and you hold it for 10 seconds, and then you blow the air out into the machine. Okay, you do not do the initial recordings. This is all dead space. So this one you discard, and then when it does the blow out, this is what you use. And this is the alveolar sample, direct alveolar sample, rather than the anatomical dead space. And then you do the calculations. So you can do multiple calculations. It really looks at the rate of carbon monoxide uptake during the 10-second breath hold. And it is also affected by atmospheric pressure, altitude, hemoglobin content, age, and gender. So these are factors which will actually change your DLCO. So you need to stabilize the whole test for all these factors. So you can actually get a percentage predicted for that age, for that gender, and for normal hemoglobin. The newer machines actually can calibrate even for anemia. So it's not a problem. They can actually, even if you've got low hemoglobin, they take that into consideration. And when the final results come out, there is a calibration of it to stabilize your readings. So the important thing to remember is this formula, the Fick's law of diffusion, because we are looking at the diffusion capacity of the carbon monoxide. Now, if you look at this formula, we are trying to find out volume. The diffusion coefficient is already established. We know that number. We know delta P, which is the partial pressure gradient, and we know the thickness. So really, you can calculate the surface area of the thing, and you can calculate the amount of carbon monoxide by using this formula. It very clearly gives you. So some of the factors are very well established. You only have one unknown factor on this side, one unknown factor on this side. So V is equal to the number that you get. What reduces DLCO? Now we said that the membrane surface area is very important. So anything that reduces the membrane surface area will reduce the amount of carbon monoxide that gets taken up. Things like emphysema. Anything that increases the membrane thickness will not allow the carbon monoxide to go across. So things like ILD. Pulmonary hypertension also reduces DLCO by increasing the pressure, the pressure across that membrane where the perfusion takes place. Hence, the amount of carbon monoxide does not diffuse easily across. And anemia directly affects the DLCO uptake by reducing the number of hemoglobin molecules available for the carbon monoxide to go in. So what are the clinical conditions in which DLCO is reduced? Interstitial lung disease, COPD. Each one of this is self-explanatory if you've understood the philosophy of the test. Pulmonary embolism, CCF, smoking, primary pulmonary hypertension, and anemia. But as I said, the new machines can compensate for the reduced anemia. What are the conditions which increase the DLCO? Anytime when the perfusion is increased, when there is more blood coming into the lungs, then you get an increase in the carbon monoxide uptake. So exercise can increase it. Supine position can increase DLCO. In asthma, there is evidence that there is increased pulmonary perfusion of the upper lobes, so the DLCO goes up. If you've got bleeding in the lung, then more hemoglobin is available in the alveoli and more of the carbon monoxide diffusion takes place. Similarly with polycythemia, similarly with mild left heart failure. All of these increase the pulmonary congestion and increase the uptake of DLCO. So this is an understanding of how DLCO is measured and what is the significance of a reduced DLCO and what is the significance of an elevated DLCO. So elevated DLCO is left to right shunts, polycythemia, exercise, intrapulmonary hemorrhage, asthma, and obesity. All of these increase the blood flow into that area, so the CO is taken up more, okay? Now this is a chart where we actually use these tests. We've done the test and we use this chart to define what is the various disease, because the bottom line is, what is the use of this test? You can do as many tests as you like, but how do you use it? So you use it by first starting with FEV1, FVC, which is normal spirometry. And then you look at this side or this side, whether it's low or high. And then you assess the FVC, and then you look whether it was low or high, okay? And if it was normal or high, then we know, we decided it was obstructive disease. We assessed the ratio, we assessed the FVC, and we decided it was obstructive disease. Now, once you've done that, you put the patient to DLCO and you look at the DLCO. If the DLCO was low, then you're dealing with emphysema. If the DLCO is normal, then you're dealing with asthma. Or if it is high, you're dealing with asthma. Similarly here, with TLC, you look at the TLC, again, if it is low, then you're dealing with restrictive disease. We said that, FVC and TLC low, restrictive disease. Once you've got restrictive disease, look at DLCO. Low, it's probably interstitial lung disease. If DLCO is normal, then it's probably a chest wall disorder, neuromuscular disease, or obesity. So this is the way we use the DLCO, the TLC, and the FEV1, FVC to actually predict which is the disease that we are dealing with. So just looking at one spirometry will never give you a complete idea. That is why when you are assessing a patient in a preoperative manner, you need to do everything. You need to do TLC, you need to do obstructive mechanical, you need to do flow volume loops, you need to do the whole thing. You need to do DLCO. It's very important because knowing the DLCO can give you a direct correlation on what is the disease. And if you look at the further guidelines, you will see that post-operative predicted DLCO is a direct correlation to morbidity and mortality. So if your DLCO has changed dramatically, it has a direct correlation to morbidity and mortality. And you'll find that when I discuss the guidelines. So it's very, very, very important that when you're going to do lung resection or when you're going to subject somebody to chemotherapy or to radiotherapy, it is important to know what is the baseline DLCO of this patient. Because it's important to know whether this patient will tolerate surgery or will not tolerate surgery. Spirometry will not give you all the answers. Very often spirometry may be normal, but your volumes and your DLCO will change. And that will directly change your decision on whether to operate or not to operate. So it's very, very, very important. Okay, so don't think that these PFTs are just, it's just one test. I know people who have operated on lobectomies and haven't even done PFTs. I've personally seen this situation. And it is criminal. It's criminal if you operate on a patient and don't do PFTs. Not acceptable in the modern world, okay? Now, before we go to the guidelines, another set of factors that you have to look is you have to calculate how much amount of lung is going to be left behind. So it's very important first to understand segments of the lung. That's why I took the first lecture on bronchopulmonary segments of the lung. So you got to know that there are 19 bronchopulmonary segments, 10 on the right side, 5 on the left. Again, we know that it's 3, 2, and 5. And then on the left side, it's 3, 2, and 4. So this, once you have this knowledge, then according to the ERS, ESTS guidelines, anytime you want to start evaluating a patient for surgery, you have to evaluate post-operative lung function. It is mandatory. And hands on heart, how many of you have actually genuinely evaluated a patient's post-op lung function? Very, very, very few people do it. But in the West, almost all of us do it. So look at how we do it. Okay, we know there are 19 segments. We want to take away the obstructed segments because really the physiology is based on what is the functional segment. So you take away the obstructed segments from 19. So you reach a value T. T is the number of functional segments that are present in the lung at the time of assessment. Then you know if you're doing an upper lobectomy, you're going to take out 3. Or if you're doing a lower lobectomy, you're going to take out 5 on the right side. So T, number of functioning segments, minus the number of segments to be resected will give you R. So you know what is T? Obstructed number of segments minus obstructed segments. So functioning segments, you know what is R, what is going to be left behind. And the post-operative predictive value is a very simple formula. You put the pre-operative value, whatever number that you got, divided by T and multiply that by R, and that gives you a predicted post-operative value. I promise you there will be MCQs for calculation of predicted post-operative FEV1. 100%. They will give you a 25-year-old comes in with a history of upper lobe cancer. His PFT was so and so and so. He is going to undergo right upper lobectomy. Calculate his predicted post-operative FEV1. This is the MCQ which comes. And until and unless you understand what is T and R, you cannot do this quickly. So you really need to understand this formula. It is very, very, very important. And using this formula, you can calculate FEV1, you can calculate DLCO, you can calculate VO2 max. It doesn't matter. The same formula is applied whether you are going to calculate FEV1, DLCO, or TLC. So this is actually what you're doing. You're looking predicted post-operative FEV1 is pre-operative FEV1 into 1 minus proportion of the lung resected. So if you look more into it, it's exactly the same formula. You actually take out the segments that are to be obstructed, and then you understand what is the functional segment, and then you divide it by the total number of segments. Okay. So pre-operative FEV1 into 19 minus segments to be removed, which is T, and divided by R, which is whatever is the number that is left behind. So similar way, it's a different representation of the same problem. Okay, so same, if you really go back and look at the two things, it's kind of difficult to understand when the lecture is going on, but when you go back, you will realize it is exactly the same situation. So you're actually calculating post-operative FEV1 using the same formula, and for pneumonectomy using, particularly when you do ventilation perfusion scans, we calculate the fraction of the total perfusion of the lung that is to be resected. And this is directly from the ESTS, okay? So it's very, very easy to calculate post-operative predicted FEV1. These are the two formulas that you have to use every single time. And the same thing you can put in DLCO. When we do for lobectomy, we use 1 minus A upon B. And for pneumonectomy, we use a fraction of the total perfusion of the lung to be resected. So we actually use a perfusion scan to give us an idea, or a ventilation scan to give us an idea of what is the perfusion of that lung, how much of it is we're going to take out, and depending upon that, we then calculate the post-operative predicted DLCO. Both of these formulas, just write it down at the moment, but when you have some time, think about it and use it to calculate some real-life patients, and you'll be surprised how well it works. So that is the importance of predicted post-operative FEV1 and predicted post-operative DLCO. So far, we have done spirometry, we have done flow volume loop, we have done DLCO, that is the gas diffusion factors. We have looked, using these three numbers, we have calculated predicted post-operative FEV1. Once we have done these are the respiratory function tests. What if some of these numbers are low? How do you go on to the next stage of calculation, which is the extended exercise test? So the ACCP guidelines tells you here very clearly, ACCP guidelines says that if the predicted post-operative FEV1 or the predicted post-operative DLCO is less than 60, ACCP uses less than 60. The ESTS ERS guideline uses less than 80. They say more than 80 is okay for pneumonectomy, lobectomy, no further testing. But ACCP talks about more than 60 is okay for lobectomy, pneumonectomy. So that's a slight difference between the two, depending on what papers each one of them are reading. But if it is less than 60, then you have to do further tests. And the two tests that are mentioned are shuttle walk test and stair climbing test. These are the two tests, and the grade of recommendation is 1C. So quite a good grade of recommendation. So you go to the next step, which is the shuttle walk test. So a shuttle walk test is 2 cones left 9 meters apart, and you ask the patient to walk around it. So you do 2 cones 9 meters apart, you do 25 shuttles and 250 meters. And what you're really looking for is desaturation. You put a oxygen probe on the pulse oximetry on the patient, and you measure the pulse oximetry, make him go around the shuttles, do 25 shuttles, and if there is a drop of more than 4% of the oxygen saturation, then you are dealing with high-risk patient. This patient needs to be further evaluated before putting him through surgery, because there is a high chance you might get a complication with this patient. Sorry, that got repeated. Okay, so stair climbing. Stair climbing is the next step that you do. Actually, the ESTS ERS talks very highly of stair climbing test. It says that you make the patient climb 22 meters. It's a very cost effective, and surprisingly, they said it is a very good indicator which predicts morbidity and mortality. If the patient cannot do this, this is a very, very good tool, even better than simple spirometry. They said sometimes stair climbing can be used as a first line test rather than using it later on. Very early in your consultation, if you ask the guy, kitne floor chad sakte ho, how much floors can you go up or down, he will be able to tell you, and that gives you an idea of whether this is a high risk patient or not a high risk patient. And you can actually decide whether if you feel he's a high risk patient, then put him through CPET. Okay, so stair climbing is very highly spoken of in the ESTS ERS guidelines. Again, you're looking for really the oxygen drop. So more than 4% drop after a stair test predicts high morbidity and mortality. And this patient definitely needs a formal CPET. This is directly from the ESTS ERS guidelines. So a lot of people do 6-minute walk test. We used to do it quite a lot in the past, but actually after the ESTS guidelines came up, they said you cannot use a 6-minute walk test to decide whether a patient should be done for surgery or not. Like in a stair climbing, if his oxygen is fine, if he's done 22 meters, then you don't need to do any further test. Whereas 6-minute walk test, the literature is a little woolly on it. We are not very clear whether if the patient does the 6-minute walk test, can we put him through for surgery or not? So ESTS ERS has actually not spoken about 6-minute walk test. They've said you should not do it. Okay. So we've done that. Now the question is, you did all the stair test and you did the thing, but here you have a guy with an FEV1, predicted post-operative FEV1 and predicted post-operative less than 30%. So if he's less than 30%, don't bother with doing the exercise test. Directly put him into a CPAP, because you need to know VO2 max. This is a high-risk patient, and we really need to know the VO2 max for this patient. So ACCP has talked about the situation where you don't need to do the exercise test, just directly put him into a CPAP if it's less than 30% predicted DLCO. And this is how you do that. ECGs are monitored. It's more or less like the treadmill test for cardiac, except that you add the breathing element to the whole picture. So you're also monitoring ECGs, but you add the breathing apparatus into the system, and what you really measure is oxygen consumption. So peak oxygen consumption, which is also called as VO2 max or VO2 peak. In the old literature, it used to be called VO2 peak. In the American literature, it's called as VO2 max. If after you've done the CPAT and the number comes back as 20, more than 20 ml per kg per minute, and actually this guy is a low risk. You don't need to do anything more, he can go for surgery. But of course, people who have got compromised DLCOs, I don't think anybody will reach more than 20. Most of them will probably reach this value. So if your value is around 12 or more than 12, then you're a moderate risk, okay? But if you're less than 10, you are a very high risk, and you should avoid these guys for surgery. You don't want to touch somebody who's got a VO2 max of less than 10 ml per kg per minute. You'll get morbidity. But the reality is, if you have not tested for it, if you've got marginal DLCO or you got marginal PFT and you've not tested for it, you will never know which patient is low risk, which patient is average risk, which patient is high risk. And that is why it's important to test for cardiopulmonary exercise. You must use it as a tool to identify the correct patient for the correct surgery. Again, you can calculate VO2 max. Predicted post-operative VO2 max can be calculated. Exactly the same formula, but you put in the values for VO2 max rather than FEV1. So this is the formula for calculating the VO2 max. So just for completion, I'm going to talk about the ABGs, because we should do ABGs in these patients. They give you, they don't give you a good indication, but they do make you understand which is a patient which will get into trouble or not get into trouble. So particularly when I'm in a borderline situation, I will sometimes use ABGs to give me an idea as to what to expect post-operatively. And more important for me, the need for preoperative ABG is important, because that gives me what is the baseline for this patient. So when he goes off after surgery or things are changing, at least I know what he was like pre-operatively. That's why ABGs are important. And I think it's a good idea to use ABG as a baseline function for complex thoracic surgery patients. It's a very, very, very good idea. So you have two figures there. One is respiratory acidosis, where the pH is falling and PCO2 is increasing, and the bicarbonate increases because of the compensation. Or you can get respiratory alkalosis, where the pH is increasing, the PCO2 is falling, and the bicarbonate is compensating. And this is the classical picture which all of us have studied of respiratory alkalosis, respiratory acidosis, and what is happening to the pH. So this is something that you must remember, but this is not part of the guidelines, okay? So it's important. All right, everybody's understood all the tests so far?
Yes, sir.
Is it clear? Have you understood
Yes,
how to do the test? Okay. So now let's come to the guidelines. What are the guidelines telling us? What should we do in a clinical scenario? So the guidelines always, all of the guidelines, no matter where you read, what paper you read, they always start with a cardiac evaluation, okay? Before you do anything, anybody fit for thoracic surgery, please make sure that his heart is okay. All right, so do history, physical examination, baseline ECG. Quite mandatory. And then you calculate the cardiac risk factors, okay? So look at any of these. So any new cardiac conditions requiring medication, newly suspected cardiac, or inability to climb 2 flights of stairs, all of these are markers. If they are no, then you go for a PFTs, but if they are yes, you need to do a cardiac evaluation with the cardiologist. You use the AHA, ACC guidelines. Depending upon that, if there is any need, you do a medical therapy. And then after medical therapy, you send them for PFTs and then send them for surgery. If there is need for coronary intervention, then you must not do thoracic surgery. People do not die of lung cancer. They die of coronary artery disease. A lot of people ask me, so what on this? He's got a lung cancer. There is mild coronary disease, or there is moderate coronary disease. Should I go through PCI? Because with PCI, he'll be anticoagulated and my patient will go away. But the important thing to remember is, if you put that guy on table with general anesthesia, rest assured he'll get an MI. And people die from MI. People don't die from lung cancer straight away. So please, if the patient needs coronary intervention, go ahead and ask them to do the coronaries. Whatever is needed, do not do the surgery at the same sitting. Wait for 6 weeks and then you come back to the lung cancer. Lung cancer is not an overnight phenomenon. If you've seen a mass, it's probably been there for 10 years as a single cell, which has been mutating and then gradually increasing in size. It's just that you've seen it today. That's the different thing. So please sort out the heart first. Do not think about the lung straight away. Okay. Again, you need preoperative ECG. You need echocardiogram. MI less than 6 weeks are not for lung resections. And any MI in the last 6 months must be evaluated for cardiology. If the patient has had a CABG, I'm very happy. CABG is not a contraindication for lung resection. In fact, CABG patient is good because his heart is functioning well. So I'm quite okay with that. And if there's any lesions on coronary angiogram, for God's sake, do the CABG before you do anything to the lung. Okay. Now let's come back to here and see here. So we've evaluated the heart. This is the ACCP guideline. We've evaluated the heart. We are happy. There is no heart problems. The risk is low. So we now do the lung function. Once you've done the lung function, you look at predicted post-operative FEV1, look at predictive post-operative DLCO. On the ACCP guidelines, we said it can be 60, 30 to 60 or less than 30. If it is more than 60, no need to do anything more. Just send the guy. He's a low risk. He can have his surgery. If it is 30 to 60, then you put him through stair climbing or shuttle walk test. If he cannot do the 22 meters, or if his shuttle walk test is less than 400 meters, and there is a 4% oxygen drop in the O2 measurement, then put him into CPET. Once you put him into the CPET, you then measure the VO2 max. The VO2 max can be 20, can be 10 to 20, or can be less than 10. If the VO2 max is 20 or 75% predicted, he can go for surgery. If the VO2 max is 35 to 75% predicted, he's a moderate risk for surgery. And if the VO2 max is less than 35% predicted, he is a high risk for surgery. Again, if your DLCO is less than 30, straight away put him into CPET. Don't bother with this. Straight away put him into CPET and calculate the VO2 max. And this will help you to decide whether your patient is low risk, moderate risk, or high risk for surgery. And then same thing on the ESTS, ERS guidelines, except that they have used 80% as their cutoff. So anything more than 80% is okay, but less than 80%, you go through the same pathway and you got to decide which are the ones who can have surgery. But if they're less than 10, again, they've said are not recommended. Surgery is not recommended, and consider other options. So do not operate on these guys. They're going to die. They will die on your operative table. And that's the last thing that you want. Okay.
What is split function in this chart, sir?
Same thing, FEV1 DLCO. That is a split perfusion. Yeah. Okay. What about ECOG and WHO scale? It is important to look at quality of life of the patient. So you must use these numbers for identifying what is the quality of the life of the patient. You can use the performance status of the patient, but these are not used in the guidelines at the moment. They are only used for risk stratification of the patient. And so you can use these as risk stratification factors. And then depending upon the number of factors, you can give a percentage risk of mortality or morbidity. And so you can use these factors in informed consent of the patient. When you're giving an informed consent, you can tell him if he's got more than 3 risk factors, you can say there's a 10% chance that you are going to need a ventilator, or the morbidity of the or mortality of this operation is 10%. So it depends on what are the risk factors. So these scores that are there, the Thoraco scores and all that, are used for risk stratification, but they are not used for defining whether a patient can go for surgery or not go for surgery. So it's very important to understand the difference between the two. So now let's go through each of these guidelines, and I will throw the statement at you, and I will throw what is the recommendation on that. So this is what we are going to look at. We're going to look at all of these factors, and I'm going to look at all of these questions, and I will answer these questions depending upon what comes up in a minute. So these are the questions that I'm going to answer. I've gone fast because it's not important. I will cover each one of this as I come to the topic. So lung cancer, you need to understand that all of these guidelines are based on level of evidence and grade of recommendation. Okay, so level of evidence and grade of recommendation. So the ESTS ERS guidelines uses the Scottish Intercollegiate Guideline Network, the SIGN. Very, very often you will be asked this question, and what is the level of recommendation and what is the grading system that you are using. So because this is FRCS, almost all of us in the UK understand the sign recommendation. So look at this. It is based on meta-analysis, well-conducted meta-analysis with low risk of bias, or with very low risk of bias, or high risk of bias. So that's 1, 1 plus, 1 double plus. Then 2 is a case control cohort study. And then these are well conducted or with risk of bias. So if the risk of bias is low, then it goes 2 plus. If it is low, if it's very low, 2 plus. If it's low, 2 plus. And then, so you just need to understand this. Go through this in more detail. Understand that 4 is expert opinion. So there is not much evidence in literature, but experts actually can add value. So it is also taken expert opinion into picture. So whenever I talk about any of the recommendations, I will say 2/B. That means this recommendation is based on good case control or cohort studies, and the level of recommendation, the grade of recommendation was B. Okay. So understand this. You need to go through it. I cannot teach on an online session. You just need to read it, and it's very, very self-explanatory. But everything we talk about now, from now on, is based on the sign system. Okay. So what does the ESTS ERS guideline talks about spirometry? It says that spirometry should be performed on every patient. Post-operative FEV1 should not be used alone to select patients for lung cancer surgery. In fact, you have to use DLCO along with predicted post-operative FEV1 to decide which patient will go for surgery or not go for surgery. Anything less than 30% is a high risk for surgery. And the prediction of post-operative PFT is recommended, highly recommended, okay? And the level of evidence is 2. So it's important to understand this. Yesterday, somebody asked me, what if I don't have a DLCO in my institution? Well, to be honest, you're not doing the patient a fair thing. This patient will die and you will not know why he has died. So if you are doing surgery only on FEV1 numbers, you're actually not following the evidence. You're not following the guidelines. It is completely wrong. You must do a split function, or you must do the gas transfer and everything to understand exactly what is happening to this patient before you take him up for surgery. So simple spirometry is not the right thing to do when you're talking about putting people through complex surgeries. DLCO should be used regardless of surgeries. So it is there in the guideline, and this is on evidence-based. This is meta-analysis. This is over the years of things they're looking at. Okay, predicted post-operative less than 30% is high risk for surgery. Level of evidence is 2 plus. So these are pretty decent, pretty well conducted studies which I've looked at. So DLCO is indicated, and the level of recommendation is B. So quite a decent level of recommendation for doing DLCO. Segment counting, which I showed you earlier, it's important to understand what is the residual function going to be on the basis of segment counting. Not obstructed should not be used. Obstructed should not be used. You should only use the segments that are not obstructed. So the value T is important. And then borderline function can be calculated on image-based calculations. Sometimes CT scans have softwares which help you. But in a pneumonectomy, they're particularly recommended using either ventilation or perfusion scintigraphy. And these will help you identify which is a good patient for pneumonectomy. Of course, this is a guy who's less than 80% or less than 60% according to ACCP. If he's more than 80%, you don't need to do a VQ scan. You can do a pneumonectomy, not a problem. But if it's less than 60%, I think the recommendation says that you should do a VQ scan before a pneumonectomy. There is evidence coming on that quantitative CT scans may actually help you with deciding for lobectomy and pneumonectomy. Again, a decent level of recommendation. Ventilation perfusion scans, people were asking me. It is important. You can do one or the other, but nowadays it's so easy to do both. So most of us do both. This is the split level function. You were asking me what is split level function? Is the DLCO and VO2 max and splitting the VO2 max into less than 20, more than 20, less than 10. That is called a split level DLCO functions. And you can use this for recommending the patient for surgery. But quantitative CT, MRI, and SPECT scan are not yet part of the guidelines. So they are used as research tool, but they are not part of the guidelines. Okay, so that's the level of academia. What about exercise tests? Should you do exercise tests? They are definitely indicated in patients who have less than 80% predicted postoperative DLCO or FEV1. In the ACCP guidelines, is less than 60%. So you must do them, and it's a good level of recommendation in there. Shuttle walk is also recommended. It underestimates exercise capacity. So alone on a shuttle walk, you cannot say that the guy is not fit for surgery. You must combine it with your DLCO and your other tests to give the analysis. So don't just say on the basis of shuttle walk, I'm going to reject him or accept him. You cannot do that. Stair climbing is also quite a good one. I told you it's very well recommended in the ESTS, ERS guidelines, and they say it is a very good correlation with morbidity and mortality, and can be used to decide which patients to put through CPET. 6-minute walk test, I told you, is not well, we really don't know what is the effectiveness of this test. Some people do use it, but literature is not clear on how effective it is. What is the sensitivity and the specificity? We are not clear about it. Oxygen drop after saturations, we said it's a 4% drop in oxygen always indicates morbidity and mortality. So you need to do a formal CPET in this group. So what about CPET? What is the recommendation? VO2 peak should be done on treadmill, highly predictive of post-op complication. So the split level function should be done to give you an idea of what is needed. You must do a formal CPET, and it gives you a very, very good prediction of what is going to happen to the patient in the post-operative. So you look for VO2 max or VO2 peak. More than 75% or more than 20 is fit up to pneumonectomy. So you can even do a pneumonectomy if the peak is more than 75%. No need for any further tests. Less than 35, less than 10 is very high risk. Try to do non-surgical treatments in these people. There's not enough evidence for the values for lobectomy. These are values for pneumonectomy. Future trends are, they want to include the performance status and the other cardiac tests as complements to tests, but at this moment we don't know. And they're trying to say that exercise DLCO may be a good technique to tell you whether the patient is fit or not fit. Okay. What about rehabilitation, preoperative rehabilitation? Smoking cessation is highly recommended, and use of drug therapy for smoking cessation is part of the ACCP guidelines. Early pre-op rehabilitation is highly recommended in people who have got compromised lung function. Early post-operative rehabilitation is highly recommended in patients who have got post-operative complications. Okay, so it is recommended, please use it. And they say that preoperative exercise and physiotherapy is inversely proportional to the morbidity. So it improves the patient's functionality, and thereby these patients who are inoperable may become operable. That is why preoperative rehabilitation is very, very important. Scoring systems, there is no such thing at the moment. They are not required for evaluation, but they are a good tool for risk stratification and for research. So a lot of us use these scoring tools for research. But really, you cannot use it as a tool to decide who goes for surgery or who doesn't go for surgery. What about the need for ICU? Routine admission to ICU after thoracic surgery is not indicated. Very clearly, it's not indicated. Most thoracic patients with moderate risk can be managed in the SDO. It's not a problem. Okay, marginal CP, cardiopulmonary reserve, moderate, or even high risk. If the patient has had a smooth surgery, you can put him in an SDU. But if he has organ failure, which means the kidneys are failing, he needs dialysis, urine output is dropping, or if he needs ventilation, move him to the ICU. But you don't need to occupy an ICU bed. This is very important because a lot of cost of the ICU is very high as compared to HDU. In fact, if it's a low risk patient, most of the times from the SDU, he doesn't even need to go to the SDU. He can directly go to the ward. But the recommendation here is very important to understand. The recommendation is he should go to a thoracic surgery. You must have nurses there who are trained to look after a thoracic surgery patient, including to identify early markers that the patient is deteriorating. Nurses who are trained to look after drains, chest drain management is very important. If you send him to a routine general surgery ward, you will miss complications. You will miss bleeding. You will miss a guy who's going off in a respiratory way, his functions. So next morning, if you come, that's no good. So that's why they have highly recommended that you must have a dedicated thoracic surgery ward if you're going to do lobectomies or complex lung resection surgeries. You cannot operate through a general surgery ward with one patient being thoracic and the next patient being lap chole. That is not acceptable actually around the world. What about quality of life after radical surgery? Specific QOL instruments are available. You can use whichever one is the standardized one. They speak about SF36. Other papers speak about other quality of life tools. But PFTs do not indicate quality of life. So, predicted post-operative FEV1 does not indicate what is going to be the quality of life for this patient. So you need to use separate tools for quality of life. And post-treatment, it is important to monitor the respiratory function. So this is what, when I was telling you that following surgery or following chemotherapy, you must repeat PFTs at 6 weeks following surgery, because you need to know really what is the difference that your surgery has made on this patient. You may not be able to tell about quality of life, but you can tell what is the physiological function of the surgery of the patient following your surgery. So it is recommended. Sometimes you come across cases who have got lung cancer in the background of emphysema, and they say that actually you can do LVRS surgery in the same sittings on the same side. You cannot do the opposite side. So anatomical lobectomy plus or minus LVRS in well-selected cases is actually part of the guidelines. What about segmentectomy? When should you do segmentectomies? Anatomical segmentectomy is recommended in small tumors less than 2 to 3 centimeters, but the margin of resection has to be more than 1 centimeter. Okay, so that's important to understand. Anybody stage 1 with poor PFTs or poor post-operative predicted FEV1, you can consider for surgery, but you must think of segmentectomies. Lung resection after prior lobectomy, you must consider segmentectomy rather than doing another lobectomy in the same lung. So it's important to understand. There is also provision for wedge resections in very high-risk patients. So if you've got a high-risk patient who cannot tolerate chemotherapy, who cannot tolerate, then you can do what is called as a wedge resection. But preferably, you should try and do it by VATS. So VATS is featured in this guidelines. Small peripheral adenocarcinomas on HRCT. But these are all people with very high risk, very poor lung functions. You can actually offer wedge resections. So 1 minute, somebody's phone is ringing. Okay. Neoadjuvant chemotherapy. What about neoadjuvant chemotherapy? After induction chemotherapy and radiotherapy, before you offer the patient surgery, you must do PFTs and DLCOs. It is important to do PFTs and DLCOs. Do not operate on the patient on the basis of what was done prior to the induction chemotherapy, because numbers change. The chemotherapy makes an effort to the lung function. Induction chemotherapy and surgery, which means lobectomy, does not increase morbidity and mortality. Less than pneumonectomy means lobectomy and segmentectomy. So people who are having preoperative chemotherapy followed by surgery, it does not increase the morbidity and mortality. Okay. But if patients are going to have pneumonectomy, say you've given chemotherapy preoperatively, but after chemotherapy, you're trying to do a pneumonectomy, very high morbidity, very high mortality. Look at the level of evidence. It's 1. Okay, meta-analysis. Its meta-analysis shows that people who undergo pneumonectomy after receiving chemotherapy have very high risk of morbidity and mortality. Same thing for chemoradiotherapy as well. Addition of radiotherapy to chemotherapy followed by surgery increases mortality. So chemoradiotherapy increases mortality even if you're not doing a pneumonectomy. So it's important to understand this statement. Okay, so you must be very careful when you're downstaging tumors and you're taking the patient up for surgery. You have a high risk of increasing the mortality of this patient. And particularly they've spoken about right pneumonectomy. They say right pneumonectomy definitely increases mortality. And look at the level of evidence, grade 1. So all of this has been confirmed by meta-analysis of data, meta-analysis of random and controlled trials. So important to take this on board. Don't just start operating willy-nilly, saying that I am a very bold surgeon and I can do any shit I like. Because really the price is paid for by the patient. Patient dies, not you. Again, look, there's an increased risk of ARDS in these patients. So be very, very careful when you're operating on these patients. All of the level of evidence is 1, not 2, not 3, it's 1. So be very careful when you're doing this. Okay. What about definitive radiotherapy? PFTs do not give you a good idea of whether a patient is fit for radiotherapy or not. That's the bottom line. You cannot use PFTs. You have to actually use dose volume histograms and dosimetries. There are dosimetry calculations, and they are the ones that will tell you whether the patient will survive radiotherapy or not. You cannot use PFT. They are not good because we don't know what is the safe lower level of FEV1 or DLCO. It's not been defined for radiotherapy. Definitive chemotherapy, again, safe lower levels of FEV1 and DLCO for chemotherapy have not been defined. So it is not included in the guidelines. High-risk patients, what are the alternatives to surgery? Radiotherapy can be used for medically inoperable non-small cell lung cancer. But if you're going to use radiotherapy, chart is preferred. Or if you've got stereotactic, then stereotactic is preferred than any of the other types of radiotherapy. So SBRT is the one they're talking about in a high-risk stage 1 non-small cell lung cancer. And other treatment options are RF ablation or PDT. So both of these can be used in these patients to offer an alternative to surgery. What centers should do it? All surgeries should go through tumor board, mandatory. Tumor board must include a thoracic surgeon, pulmonary oncologist, pulmonary radiotherapist, pathologist, radiologist, and a pulmonologist. It's mandatory. Thoracic surgery should not be done in small centers, small hospitals. It should be done in specialist centers because this is complex surgery. This has complications which have severe impact to the life of the patient. So it really needs a thoracic surgeon to operate on these people or somebody with expertise in thoracic surgery. And what do we mean by expertise? They say somebody who does at least 20 to 25 lung resections a year. There is a direct correlation. All literature has suggested that there is a direct correlation to the number of lung resections a year that you do to outcomes. So only people who are doing more lung resections will actually have good outcomes. Otherwise, patients will suffer. So when we talk about high volume center, we are not talking about 20 to 25. We are talking the minimum number that you need to know, that you need to have to even stay qualified as a thoracic surgeon is 20 to 25 lung resections. In fact, in UK, for you to have a license of thoracic surgery, it's around 10. You need to do minimum 10 lobectomies, even to be licensed to continue as a thoracic surgeon. But to do these complex resections and lobectomies and things like that, at least 20 to 25 lung resections a year is important. Again, for chemotherapy and radiotherapy, they suggest high volume center, but the level of evidence is a little low on chemotherapy and radiotherapy. But for surgery, the level of evidence is there to suggest that volume makes a direct impact on outcome of the patient. A quick look at the ACCP guidelines. This is the last 5 minutes or so in this talk, but very important because this is a beautiful guideline. I really love this paper. And everything is very straightforward and bang, bang, it has been stated. So let me tell you the recommendations. Let me not go through too much. It says all lung cancer, tumor board 1C. Age is not a contraindication. This is the first time in the guideline that age is coming into the factor. And age is not a contraindication. You need to fully evaluate it. And if you've got an 80-year-old guy who's got a post-operative predicted DLCO of 80%, there is no reason why you should not offer him surgery. You understand that? So that is what they're saying. Age is not a contraindication, and it's 1C. That's quite a decent recommendation. I'm quite happy with that. We operate on people. Most of our people are 70, 80 years, 85 years. So age is no longer a contraindication. Preoperative cardiac evaluation is highly recommended. Okay, it's highly recommended. All patients, you cannot start doing thoracic surgery evaluation till you've cleared them from a cardiac point of view. You must do FEV1, DLCO, and you must calculate predicted post-operative FEV1 and DLCO. Anything more than 60 does not need any further testing. We said that earlier. Anything between 60 to 30 should undergo shuttle walk or a stair climb test. Anybody with less than 30 should undergo CPET or VO2 max. On a stair climbing test or shuttle walk test, you are less than 25 shuttles, less than 22 meters, 4% drop in oxygen saturation, you must do CPET or VO2 max. VO2 max less than 30, less than 35% predicted, you should not operate. Preferably, you should not operate. If you can avoid it, you should avoid it. If you have to do, you have to do a sublobar resection, and you must do it by VADS. So it's very, very clear about it. This is again the first time that minimally invasive surgery is appearing in the guidelines. Neoadjuvant therapy, if you've given neoadjuvant therapy, you have to repeat PFTs with DLCO after the therapy before he is considered for surgery. So you have to look at new numbers, not the old numbers. You can do LVRS plus lung cancer surgery, quite important. Smoking cessation, tobacco dependence therapy is highly recommended, you must do it. High-risk surgery, you must do pre and post-operative pulmonary rehabilitation, again recommended, 1C, that's quite a good recommendation. So these are the ACCP guidelines. I want again this message to go home. Please, please take these last two slides very seriously. I've said this at the start of my talk, and I want to say it at the end of my talk. The real important outcome in any surgery is a live patient. If you do not evaluate the patient, if you do not pick up the correct patient, you will end with morbidity and mortality. And the most important thing is you may be brave, you may say, I can do this, I can do that, I can do whatever you like, but the risk is actually being taken by the patient and not by the surgeon. The price for your stupidity and the price for your foolishness is paid for by the surgeon, because by the patient. The patient will suffer, not you. Okay, so for God's sake, use these guidelines and please be selective in picking up the correct patient for surgery. It should not depend upon, I want to increase my practice, I want to do more lobectomies. That is the most stupidest outlook you can have in life. You know, somebody sent me a patient, I don't want to let him go, so I will operate, no matter what is the risk to the patient. Because at the end of the day, the person who will suffer is the patient. And indirectly, I promise you, one medical legal case and your career can be down the drops. Thank you. Okay, come in guys and let me stop sharing. Okay, did that make sense? A hell of a lot of topic to cover. Okay, you can now come in and start asking me questions. I'll continue the recording till the question and answers are finished. Okay, you want to raise your hand? Okay, Fitoon, you raised your hand. Tell me what you want.
Yes, sir. My question was about the DLCO test. So initially we said it doesn't depend on perfusion, right? It depends on diffusion. And then we said if we have increased blood flow, like in exercise or other conditions where there is increased flow, then the DLCO will increase. So I got confused.
No, it predominantly depends on diffusion rather than perfusion, but perfusion also affects the DLCO. Okay. The carbon monoxide capacity, the carbon monoxide, it's not the DLCO, it's the carbon monoxide molecule. The capacity of the carbon monoxide molecule to go across the capillary membrane depends upon the diffusion capacity of the carbon monoxide. Okay, that was the statement I made. It doesn't depend upon the perfusion of the for the carbon monoxide, but the test, the whole test depends on perfusion. It is diffusion plus perfusion. So I will take away that second statement. It is diffusion plus perfusion. When I said that, I said for the molecule of the carbon monoxide. I did not talk about the test.
Okay,
So
I understand.
carbon monoxide selectively goes across the membrane without worrying about how much blood is coming in. But
Okay.
eventually, when you calculate the volume and you calculate the number, you'll find more blood coming in, more hemoglobin in the picture, more carbon monoxide goes across.
Yeah, thank you so much.
So don't get confused with that statement. I'll take it away from there. It was to talk about the carbon monoxide molecule, not about the test.
Yeah, I got it now. Thank you.
Next. Anybody else has got any questions? Oh my God, the topic must have been very clear.
Sir, this is Vivek, sir.
Yeah, Vivek, go ahead.
Sir, is there any contraindication to do spirometry?
Not really.
Because we were told,
yeah, go on.
sir, we were told that if the patient is having hemoptysis, even a slightest history of hemoptysis, do not go ahead with.
Yeah, that is a different scenario. That's inflammatory lung disease. We are talking about lung cancer.
Okay.
That is inflammatory lung disease. In lung disease,
Yes.
inflammatory lung disease, hemoptysis, that's a different scenario where you are operating to save life.
Yes.
You're not operating to, take away the cancer. So that is a different situation. That
No,
is
sir, even slightest of hemoptysis history, do not go ahead with spirometry. That's what we were told.
not
that
really. No,
Not
really. No, we're talking about it. In inflammatory, yes. In lung cancer, no. You have to do you cannot operate on a guy with in fact, if he has got hemoptysis, I'm more concerned that the tumor is more proximal.
Yes.
And medico-legally, you will never ever be forgiven for operating on a guy without spirometry.
Yes.
There is no guidelines. Nowhere have I read this
Yes.
that you don't do spirometry if there's hemoptysis.
Yes.
You do that when it's a life-saving situation.
Yes.
I have done surgeries, lobectomies for patients who were having acute hemoptysis, and I just took them to theater straight away. From that night, I took them to theater many a times.
Okay.
But for lung cancer, I have never done it. Never.
Okay.
You have to actually know the numbers. I promise you, I have never operated on a lung cancer without PFTs.
Okay.
A smart lawyer will rip you apart if your patient dies.
Okay.
Yeah. Okay. Next. Anybody else has got any other questions? Is it all clear?
Sir, sir, can I ask a question, sir?
Yeah, who is it? First, you have to tell me because I can't see everybody.
Sir, Vishwarup, sir.
Yeah, Biswarup, tell me.
Sir, in the restrictive pattern of lung disease, you have given that mildly 70 to 79%, moderate is 60 to 69, severe is 50 to 59, but very severe is less than 35%. So 30 to 50% are severe or very severe?
Less than 35 is very severe. 30 to 50 is, I'll have to look back at the numbers. It's not coming off the top of my head. It's 2 hours down the road. My brain is a mush at the moment. But it is probably moderate to severe. I don't remember the number at the moment. So there must be some. It must be a typo on my part, probably. I'll have to look back at that slide. I don't remember what numbers I put up there. It must be a typo, Biswarup, because usually they are all covered. There is no group that is not covered in the range of numbers that we are mentioning. So I'll look at that slide and I'll email you. I'll WhatsApp you. I don't remember now. It must be a typo on my part.
And sir, one more thing regarding the reduction in the residual volume for the obstructive and the restrictive. What I understand is that in the obstructive, the RV reduction is more than the reduction in the restrictive. Is it true, or I'm getting it wrong?
Come again. Go a bit slow. I'm trying to understand what you're saying.
In the obstructive lung disease, the reduction in the residual volume is more than the reduction in residual volume in the restrictive lung disease. Am I getting it right?
No, both of them have a reduction. In obstructive lung disease, the residual volume increases.
And
in restrictive lung disease, the residual volume may or may not increase.
Okay.
I am confused at the moment, so I'm sorry, I'm not able to answer your question very well.
Okay,
my brain is not able to process your question, to be honest.
Sir, I'll WhatsApp you the question, sir.
WhatsApp me the question so that I can think about it. At the moment, I have 2.5 hours of talking. I'm not able to pick up on the finer details of your question. WhatsApp me. When I clear my mind, I will think about it.
Sure.
If you've got broad questions, ask me. If you have finer details, then I will have to look back at the slide. My brain is not working clearly because obviously, I've been talking nonstop.
Thank you, sir.
Yeah, these finer points I will clear to you. Just send me a WhatsApp. I will look at it.
Sure, sir. Good night, sir.
Yeah. Clinical issues. Anybody's got any clinical questions? No? Okay. Thank you very much, everybody. And I hope you enjoyed. It was again.
Thank you, sir.
2 hours and 15 minutes, 2 days
Thank
on
you,
the
sir.
trot for you guys. Okay.
Thank you.
Thank you very much.
Thank you, sir.
Just hang on 1 minute. There are some questions which have come through here. Let me just have a quick look at them. It is recording. Is it recording? Yes, it is recording.
Yes.
Recording.
Yeah. Okay. Please switch on microphones. Okay. So something Biswarup has put these numbers. I'll look at it, Biswarup. I don't remember at the moment. I'll have to go through the slide again.
Okay, sir.
It's got to be a typo. It cannot be that something is missed out. So it's probably I've typed it. I have to make these slides for you, so I must have typed it wrong or something. But it's just an understanding of what is mild, moderate, severe, and very severe.
Classification is mild, moderate, moderately severe, severe, and very severe. One is missing, just that. That is type.
Is that probably that's what I must have missed one.
Yes, sir.
Okay. All right. Fine. Thank you very much, guys. And
Thank you, sir.
my next topic is going to be on solitary pulmonary nodule. There's a lot of guidelines on it which you need to know. There are 3 or 4 guidelines on it. If I finish writing the whole thing by tomorrow, I'll do it tomorrow evening. If I don't finish, then I'll probably do it the next day. I have a presentation ready, but because I'm doing it for you exam going people, I need to really add more stuff into it so that we cover every little bit of solitary pulmonary nodule. Okay. All right. So I'll let you know tomorrow whether we go ahead with the meeting. If not tomorrow evening, then we'll do it the next. Okay. Thank you.
Thank you so much.
Thank you,
Thank you
sir.
very much.